Thank you.
I invite Dr. NEENA. She is the head of the department, Giridhar Eye Hospital in pediatric ophthalmology, and she is a well-known figure. And she is going to present a case when first impressions deceives, a diagnostic dilemma.
So thank you, Soumya and KSOS, for this opportunity. So this was a case which is really close to my heart because it saddened me deeply because I diagnosed it. So this was a 17-year-old girl who came to us during the COVID time. Her brother had bought her with sudden painless drop in vision in the left eye of 3 days duration. So you can see here she had good vision in the right eye. The left eye vision was only hand movements close to face. Color vision was impaired, could not be checked in the left eye because of the very poor vision. But there was a definite RAPD in the left eye, and everything else was normal. Fundus looked normal. So when you took the history, there was no associated trauma or fever preceding it, no associated floaters or flashes. When we kept on digging and asking her, she said, yeah, she's been having dull headache for the last 3 years, and we think it's due to migraine and exam stress, no other past medical history. So the fundus looked normal to me. It looked normal to me then, and it was normal, I think. Yeah, so when we did the serial investigations, we started with OCT. OCT showed normal RNFL thickness. You can see here the left and right eye are almost okay. Retrospectively looking back, perhaps there was a mild GCL thinning in the left eye. If you compare the absolute values to the right eye, there was a minimal GCL thinning. We didn't think much of it then. We did a visual field of the right eye. Right eye was okay, except for some mild peripheral constriction, which I was sure that if I repeat it, it will come as normal. But since there was an RAPD, definitely there is an optic nerve pathology. So we did a VP. We could do a flash VP because of the poor vision in the left eye. The right eye was normal. In the left eye, there was a prolongation of inter-eye latency between the two eyes with some reduced amplitude in the left eye. That's what we thought. So clear cut. What is this? It's a case of retrobulbar neuritis. 17-year-old girl typically fits into it, right? So the brother was very anxious. She was going to write the exam. So they urged me to give her IVMP that day itself when I explained that this could be a retrobulbar neuritis. But then I strongly always believe that, get an imaging done before giving a high-dose steroid. So I insisted on an imaging. And, that came as a shocker to me because the radiologist called me up and he asked me, what are you suspecting here? Because I'm seeing something in the sinus. So this was, you can see how the yellow arrow points to this mass lesion in the posterior ethmoidal sinus, which was eroding the bony walls and extending to the orbit and compressing the left optic nerve at the orbital apex. But what was peculiar is that if you have an orbital apex syndrome, you would expect the other cranial nerves to be involved, right? You would expect some orbital changes, some proptosis, some extraocular motility abnormalities. Nothing of that sort was there. It was just presenting with an optic neuropathy. So the commonest space-occupying lesion with an asymptomatic patient is usually a fungal sinusitis. So this was the differential he gave. Could it be a fungal sinusitis? Could it be allergic, invasive, because it was eroding the bony wall? So he asked me, is she immunocompromised? I said, no, she's a healthy 17-year-old girl. So I decided, I was like confused, and I decided to get an opinion from our ENT colleague. That's when he also said, it looks like fungal sinusitis. I'll do a FES, remove the whole thing and clean her up and give back to you. You can give her IVMP. Because fungal sinusitis can also sometimes produce, optic neuritis kind of picture. It responds beautifully to IV methylprednisolone. It's not the invasive fungal sinusitis, it's the allergic fungal sinusitis. Okay. So what they usually do is they get a biopsy from the sinus mucosa, and if the sinus mucosa is invaded, it's invasive fungal sinusitis, then you need a Brima along with antifungals. But if the mucosa is not invaded, it is, usually allergic, and they give IVMP. But then he called me from the table and said, look, doctor, this is not fungal sinusitis. There is a bony lesion sitting there in the posterior ethmoid. I am not sure what it is. It doesn't look good. I'll take a biopsy and, I will decompress the optic nerve and give her IVMP, but I don't like it. So That's when we sent for histopathology, came as a shocker, undifferentiated cells, all this, funny looking cells, moderate to strong speckled nuclear positivity, all Greek and Latin to me. But the histopathologist read suspect nut carcinoma. I didn't know what it was. I read about it. 1 month later, she was no pale in that eye. Orbital signs happened. Repeat MRI, residual lesion in the sphenoid. She underwent chemotherapy. They spread to the other side. She became bilaterally blind, and in 5 months later, she developed extensive She underwent excenteration eventually, but she succumbed to the disease 5 months later after having extensive skeletal metastasis. So we published this report, but we lost the patient. So anyway, it was like, because that's when I realized that this is nut carcinoma. It's a rare cancer, which is expressed in the normal spermatocytes and also in the ciliary ganglion. And what it does is it has translocations and it activates oncogenic transformation of normal healthy dividing cells. It's a rare invasive squamous carcinoma with a median survival rate of less than 1 year. And it has extensive necrotic metastatic lesions and no standard of treatment known at present. So my key point to consider here would be that always image, because imaging picked up the SOL, and it was the biopsy that was crucial, but histopathology clinched it, and immunohistochemistry, strong positivity, certain markers clinched the diagnosis of nut carcinoma. So keep it in mind, rare things can happen, and retrobulbar optic neuritis is a clinical diagnosis. The cause can be anything.
Thank you, Dr. NEENA. It was a very interesting case, and unfortunately, it was very unfortunate for that child as well. But the key message is that whenever you get an RAPD, in any case, and you are suspecting a retrobulbar neuritis or whatsoever, you're not able to see anything, like as ma'am told, it's better to neuroimage the child, because even in case of an optic neuritis or retrobulbar neuritis, to see how extensive is the lesion, it is important to image the child always. Anything else to add on?
I just have one more question. When you have, this is a 17-year-old, I think. So if you have a younger child, OCT, when you check the ganglion cell, do you take an absolute value as some cutoff or something, or because normative data is not available, or you compare with the other eye?
Actually compare with the other eye, because we don't have normative data, but we know that roughly, like let's say if the values are less than 40, 30 or something, I'm talking about only ganglion cell, not IPL complex, it's on the thinner side, and especially if the other eye is higher. But here I didn't think of it in then, but retrospectively, I saw that there was some minimal thinning.
Okay.
Plus GCC, when you take, you can take it as always a baseline, because if suppose not in this case, any other case, when you do a follow-up, you will know whether the GCC, it's getting affected in the other eye also, the normal eye. So it's always a baseline report for us.
Yeah.